Hi, everyone, and welcome to today's webinar, COVID-19 Guidance for Dental Assistants. My name is Ashley McDermott, and I am the Director of Education of OSAP, and I will be your moderator. This webinar is supported by a contract funded by the CDC Division of Oral Health. The contents of this webinar are solely the responsibility of the speakers and do not necessarily represent the official views of the CDC or the U.S. Department of Health and Human Services. Next slide. Before we get started, I'd like to go over a few housekeeping items. You will be in listen-only mode throughout the webinar. You can test your audio by clicking Audio Settings in the bottom left-hand corner. If you need closed captions, click on the link provided in the chat. Next slide.
Sorry.
You can submit questions by typing them into the Q&A feature. You can check Send Anonymously if you do not want your name attached to your question. Our speakers will address content-related questions at the end of the webinar. The chat feature has been disabled for participants, but we will be sharing resource links in the chat throughout the webinar, so be sure to watch out for those. This webinar is being recorded, and the recording will live on the OSAP website. Next slide. Now for a bit about OSAP. OSAP is a nonprofit membership organization, and our mission is to be the leading provider of infection prevention and control education, training, and credentialing that supports safe dental visits. Our vision is that every dental visit is a safe visit. Next slide. OSAP is a one-stop shop for infection control and safety information, education, and training. Next slide. OSAP worked with the Dale Foundation to develop the OSAP Dale Foundation Dental Infection Prevention and Control Certificate Program. The certificate program is available online and can be completed on your own schedule. For the latest information, you can visit dentalinfectioncontrol.org. Next slide. OSAP is an ADA CERP recognized provider and designates this activity for 1 CE credit. Instructions to claim will be provided at the end of the webinar. Next slide. I would now like to introduce our two esteemed speakers. Eve Cooney is the Executive Associate Dean at Pacific Dugoni School of Dentistry in San Francisco, California. She has published numerous articles and textbook chapters on safety and infection control and presented hundreds of CE programs domestically and internationally. She has worked with universities, nonprofit organizations, and government agencies worldwide to educate dental professionals in infection control and safety and assist in developing sustainable oral health improvement projects. She is also the chair-elect of the OSAP Board of Directors and has earned the OSAP Dale Foundation Dental Infection Prevention and Control Certificate. Kathy Eklund is the Director of Occupational Health and Safety and the Forsyth Research Subject and Patient Safety Advocate at the Forsyth Institute. She is adjunct faculty at Regis College Dental Hygiene Program, where she teaches a senior level course called Evidence-Based Decision Making. She was the 2017 to 2019 chair of the OSAP Board of Directors and a consultant to the ADA Council on Dental Practice. She serves as faculty for the New England AIDS Education and Training Centers and HIVdent.org. Over the past 35 years, Kathy has published papers and contributed to several texts on infection control and safety. She is an author of the 2003 CDC Guidelines for Infection Control in Dental Healthcare Settings and has lectured nationally and internationally on these topics. Everyone, please join me in welcoming Eve and Kathy.
Thank you very much, Ashley, and welcome to all of you. This is Kathy Eklund. You all have before you the learning objectives. We're going to describe the current interim infection prevention and control guidance for dentistry, identifying strategies and resources for implementation and evaluation, and discuss the impact on the roles and responsibilities for the dental assistant. And before I begin, I just want to highlight a long-standing belief that I have held for many years, that the dental assistant is truly the backbone of the infection prevention and control program in any dental healthcare setting. So thank you all for what you do. And I know right now in these very trying times, you can really rely on credible information, especially from CDC. The CDC interim guidance for dental settings was last updated on December 4th. And we're going to take you through some of that, as well as discuss some other aspects of the infection prevention and control guidance. On December 1st, for those of you who may be involved with any type of school-based sealant program or outreach program, CDC Oral Health Division also published interim guidance for school-based sealant programs. Now, in addition to the dental guidance, CDC refers to the CDC framework for healthcare systems. And this is really to provide care in the safest way possible, which can include things such as telehealth. And I'm sure that many of your practice settings, especially early on in last spring and summer, was doing a lot of teledentistry and following infection prevention recommendations. But it's also very much about knowing what the local epidemiology is of the prevalence and incidence of COVID-19 is in the communities that you serve. So that's why it's so important to be on listservs for your state and local health departments, so you're really aware of what the spread is like. And as we know now, clear across the United States, we're seeing skyrocketing, increasing numbers. You have to then, when you see this increased spread, think about prioritizing procedures that may cause harm if they're further delayed, and also prioritizing at-risk patients that would benefit most from care. So this is an important document along with the interim guidance. The Occupational Safety and Health Administration, OSHA, early on published the risk pyramid, and it really looks at that sort of hierarchy of what you're doing, looking at potential low risk administrative duties where people don't have front forward facing contact with patients. Moderate risk would be for urgent or emergency care without aerosols. And then high risk would be aerosol generating procedures or APGs on well patients and any procedure on a COVID-19 patient. And obviously very high risk would be aerosol generating procedures on known or suspected COVID-19 patients. So looking at that sort of low, medium, high, and very high risk. This is accessible as well as for various documents related to OSHA regulations and guidances during COVID-19 on the OSHA website. Now, we're all very used to and have for many years practiced standard precautions, which is really that set of infection prevention and control practices that are used to reduce transmission of microorganisms in healthcare settings, including dental healthcare settings. Standard precautions protect both healthcare personnel and patients from contact with infectious agents. Keeping in mind, there's the 2003 CDC guidelines for infection control in dental healthcare settings, and then also the 2016 documents supporting the 2003 guideline that are both useful resources for you. When to use standard precautions? This is by healthcare personnel for patients regardless of the patient's diagnosis or whether or not the patient is known to have a communicable disease. So we've treated for many, many years patients and personnel as if they would potentially be infected with, say, a bloodborne pathogen like HIV or hepatitis B, knowing that those standard precautions do and can work very well. All patients, all the time. Standard precautions, the elements include hand hygiene, which would include both hand washing as well as the use of alcohol-based hand rubs, personal protective equipment or PPE, and we now know that the entire world knows what PPE means. Respiratory hygiene and cough etiquette. Here we have an extreme emphasis on this now during COVID-19. Sharp safety, including engineering and work practice controls to prevent sharps injuries and incidents, and safe injection practices. Sterilization and disinfection of instruments and devices has remained the same under standard precautions and also during interim guidance. Cleaning and disinfecting of environmental surfaces and use of surface barriers for difficult to clean contact surfaces. These are all components or elements that when they're integrated together help to provide a comprehensive, programmatic, and systematic approach to standard precautions. Infection prevention and control during COVID-19. Now we're looking at elements of transmission-based precautions, which we've really not spent a lot of time talking about and addressing historically in dentistry. This is including additional engineering and work practice controls, things such as limiting people in the facility. I know many of you probably have policies in your practices where you tell your adult patients that they need to come alone, not bringing others with them unless they need assistance. And suspension of some aerosol generating procedures, such as hygiene procedures, not doing air polishing, ultrasonic scaling, supplemental ventilation, and also personal protective equipment considerations, which include not only the type that you're wearing based on the procedures being performed, but also the donning, the putting on and doffing, taking off, as well as disposable items and the appropriate management for reuse of those reusable items. Now, transmission-based precautions, they're modes of transmission that standard precautions are at the base. And these are additional precautions on top of your standard precautions based on a known or anticipated infectious agent that has specific mechanisms of transmission. The three principal routes of transmission are contact, droplet, and airborne, and we'll be talking about each one of these. So transmission-based precautions, as I said, are for patients that are known or suspected to be infected or colonized with infectious agents. These are particularly epidemiologically important pathogens. They require these additional control measures to effectively prevent transmission. And as I said, they're implemented in addition to standard precautions. For contact transmission, there's direct transmission. And this is where microorganisms can be transferred from one infected person to another without a contaminated sort of intermediate object or person. This would be a direct mucous membrane contact from someone that may be coughing or sneezing. Herpetic whitlow is another example, and this is a herpes virus infection, usually of the digits of the fingers, from contacting herpes virus, say from the oral mucosa of a patient if someone was not wearing gloves. I've been in dentistry since 1975, and I have colleagues, both dentists and hygienists, who have suffered from herpetic whitlow, which was a contact transmission when we were not wearing gloves. Now, indirect transmission is a transfer of an infectious agent through a contaminated sort of intermediate object or person, and this would be hand transfer via contaminated surfaces and equipment. Instruments that may be inadequately cleaned and sterilized between patient uses. Now, droplet transmission, this is really respiratory droplets that are carrying infectious pathogens, and they transmit infection as they travel directly from the respiratory tract of the infectious individual to the susceptible mucosal surfaces of the recipient. So when the infected person coughs, sneezes, or speaks, and we've heard a lot about that during COVID-19. During procedures such as suctioning, endotracheal intubation, cough induction by chest physiotherapy, and cardiopulmonary resuscitation, all mechanisms of potential droplet transmission. These are pathogens are transmitted via this droplet route and have not been transmitted through the air over long distances. Coronavirus, again, is predominantly transmitted via droplets. Now, with SARS-CoV-2, CDC recommends droplet precautions, but additional precautions, airborne precautions, if you're performing aerosol generating procedures, APGs. Now, evidence from SARS 2003 was that airborne transmission over a limited distance, such as within a room, has been suggested, though not completely proven. And this is also true of other infectious agents, such as influenza viruses, noroviruses, and others. Now, droplets and droplet nuclei. Droplets are generally considered to be greater than or equal to 5 microns or 5 micrometers in size. Whereas droplet nuclei are the particles arising from this sort of desiccation, you can kind of think of it like evaporation of these suspended droplets, and they're defined as less than 5 micrometers or microns in size. And these are the ones that have been associated with the airborne transmission. Organisms transmitted by the droplet route do not usually remain infective over long distances, and for the most part do not require special air handling or ventilation. Now, with droplet precautions, guidance includes patients being placed in a single room. So if you have closed operatories, ideally that would be what you would want to put the patient in that closed operatory. The patient wears a mask whenever outside of the room, and providers wear a mask upon entering the room. Special air handling and ventilation are not necessarily required, and for droplet precautions, respirators are not required. Now I'm going to turn it over to Eve, who's going to go over airborne transmission.
Kathy, and welcome everybody. Thank you for joining us for this webinar. So airborne transmission is, of course, of great concern when it comes to COVID-19, because as Kathy mentioned, when if the virus is in patients' respiratory and oral fluids, and those fluids are aerosolized, small particles can arise, both from the droplets being desiccated, where the fluids have evaporated off, making the droplets lighter and able to be suspended in the air longer than they would be when they're in their more fully wet form. So, typically a droplet, when somebody coughs or sneezes, isn't going to travel too far and it drops to the ground. But if that becomes a droplet nuclei, it's going to stay suspended longer and could potentially be picked up on airflows and carried a greater distance than just a droplet would be. And then there are other types of small particles, that are found in it, for instance, in the aerosols that are generated during dental procedures that could be small enough to be what's called the respirable range, which is less than or equal to 5 microns. And by respirable, it just means that it can make its way farther down into a person's respiratory tract. It's not just a mucous membrane contact. So when airborne transmission occurs, that's when these droplet nuclei or smaller particles contain infectious agents. And these agents that can remain infective over time, so after they leave the body, they can retain some the ability to infect other people, and that they also can travel the distance being borne by these small particles. Mycobacterium tuberculosis, which causes TB, is certainly one of the examples of infectious agents or diseases that can be transmitted by the airborne route, but so is the virus that causes measles and the virus that causes chickenpox. And I think there's enough evidence for us to be able to say that the SARS coronavirus 2 that causes COVID-19 may also, under certain circumstances, be transmitted via the airborne route. Next slide, please. Also, sometimes it's kind of good to put this in context, because it's not a clear line between airborne and non-airborne. Could you go back? Oh, sorry, that's it. There's 3 different classifications of airborne transmission. The first one would be called obligate, and that's where the microorganism is obliged to transmit under airborne because it really doesn't transmit any other way. And a very classic example of that is tuberculosis. It's transmitted not through contact with contaminated surfaces, but only through breathing in the airborne particles that are small enough to be in that respirable range that we talked about. But then there are a number of other organisms that can be transferred via the airborne route as a preferential type of classification, where it usually does occur through numerous routes, but it prefers to go the airborne route. And so that would be measles and varicella or chickenpox, as we talked about before. They can be transmitted through other means such as droplet or contact, but they really are primarily airborne. And then finally, the one that COVID-19 most likely falls into, although this is not, the evidence is still being put together on this, but these are the opportunistic route is where you have an infectious agent that naturally causes disease through other routes other than airborne, either through contact or droplet, but under special circumstances may be transmitted via these fine particle aerosols. And that includes things like smallpox, the SARS from 2003, influenza, and norovirus. Next slide, please. And one of the things to keep in mind when we determine whether or not it's safe to treat patients in any setting, including dental settings, is whether or not the patient is diagnosed or known to be infected with an airborne disease. And I know we're talking about COVID-19 today, but this would be true for any other airborne disease. If you need to take airborne precautions, so you have a disease like influenza or measles or chickenpox or COVID-19, if they're going to have any type of aerosol generating procedure, or if they're going to be in the office for any length of time, the preferred placement would be in an airborne illness isolation room. It's called an AIIR. And these are rooms that are specially designed, usually in a hospital setting, where they have a negative air pressure, and that pressure is monitored to be at a certain level, and that there are 12 air exchanges per hour. Older facilities could have 6 air exchanges per hour, but 12 is not what you would normally see in a regular office-based setting. And air exhausted is directly to the outside, or if it is recirculated within the building, it's through HEPA filtration. So the take-home message for this really is that most of us aren't set up to treat patients who are known to be infected or suspected to be infected with COVID-19. So those patients should have their treatment delayed or deferred until they are no longer infectious. Or if it's an emergency that can't be dealt with pain medications, telehealth, antibiotics, you would need to be able to refer them to a facility that does have the AIIR available. Next slide. So what are some of the other things that you can do? I mean, there's some elements of all precautions, standard precautions, droplet precautions, airborne precautions that we can implement that are based on the CDC guidelines, the interim guidelines, to help make a safe environment for care, because of course dental care is essential and can't be delayed forever. So when you can, you still should try to avoid aerosol generating procedures. It's still recommended that ultrasonic scalers not be used at this time, and that if you do need to use aerosol generating procedures, implement things like four-handed dentistry, high volume evacuation, and dental dams that'll help limit the spread of the aerosol that's being created, and then limit the number of dental healthcare personnel who are present during the procedure to those that are essential for patient care and procedural support. Next slide. There are also some things, if you haven't already done, to think about in preparation and also in just creating a safer environment where there's less chance of people sharing things that have been touched by others. Gives you the ability maybe to have surfaces that can be easily disinfected and things that are either disposable or can be wiped down. So things like considering labeling or crossing out or placing signage on chairs so that you can create appropriate social distancing in waiting rooms and reception rooms. And then reduce the use of that waiting area, though. Some of the things that you could do is you could tell patients to text or call the office when they arrive, and then just to wait in the parking lot until you text them or call them to let them know that their room is ready. Or you could have a doorbell, if possible, if you have, say, a separate waiting room where a person could ring and wait outside. You could limit or restrict accompanying family members. I think that's a really good thing to do, is to say, during this pandemic, it's really important for us to keep everybody in the office as safe as possible. In order to do that, we're asking all patients to come to their appointments alone unless they need support or help. For instance, children, or if you have somebody that's a special needs patient. Because it is important to increase the house cleaning, just the regular cleaning of the waiting areas, the registration desk, and the restrooms, actually creating a job list and a schedule to make sure that that does get done if you're not in a big building that maybe has janitorial staff to do that. And then when you are doing these extra cleanings and disinfecting, be sure to emphasize high touch surfaces. Think about door handles, counter edges, the arms of chairs, the things that we know that people really do touch a lot as they are making their way through the dental facility. Next slide, please. And of course, screening is important to do. Screening patients, think about where are you screening currently, or if you're not screening, where will you do it? It should be before they entered the facility if possible, which I know that's not always possible, but are as close as possible to the entrance. And that's because if somebody fails the screening, it'll be a lot easier to manage the the things that you need to do afterwards, such as disinfect any areas where they were, if they haven't actually been into the clinical part of the office. Determine which questions you'll ask. That may vary depending on your location. For instance, the school where I work, we're in the county of San Francisco in California, and the screening questions that they have us ask are a little bit different than the ones that the CDC has recommended. So you need to know what your local health orders and health guidelines are. Temperature screening should be a part of the patient screening. You're looking for a temperature of 100 degrees Fahrenheit or lower. And then consider verbal questions so that you don't have to have paper that's being handled by the patients. And of course, instruct patients to wear a mask or face covering until they're seated in the exam area, and it's time to start treating them, and they'll be instructed when that is. And then what are you going to do? Think about this, because I can tell you from experience that trying to deal with either an employee or a patient that has symptoms or test positive, trying to deal with it at the time you find out about it makes your job a lot harder. So having a plan in place, what are we going to do if a patient is screened and doesn't pass? Exactly, what will we tell them? Where will we send them? Who will be responsible for the cleanup and the follow-up? Is it an emergency? If we can't treat them, can they be referred for emergency dental care? And if so, which facilities in our area can we refer them to? Next slide. And then also looking just at the workspace within the office. I mean, every dental facility is different, whether you're in a renovated house that's now a dental office, a big medical dental building, or, like us in educational institutions, we might be in schools that have, 200 dental chairs. And we really all of us though, have to look at our workflow, create single directional pedestrian paths wherever possible. If you have multiple hallways, having each one go, people going in one way and out another whenever possible. It's also good to determine where in the clinical setting will you put on and take off and store your PPE, because we're going to talk about this in a minute, but there's a difference today in the sequence in which we put on and take off our PPE, and even the timing in which we do it that's being recommended. That's different than what we're used to, or that most of us are used to. Also, you may have to alter the schedule a little bit to allow patients to be alternated. So if your chairs are too close together, you're in open space, you may need to leave it one chair empty while another patient's being seen. And then when they leave, use the empty chair while you wait for the other one to be cleaned. Look at your heating, ventilation, and air conditioning systems. That's HVAC, and your airflow. You can figure out which one of your vents brings air in and which one takes it out by just holding a tissue up to it. If it's pulling the tissue towards the vent, that means the air is exiting that way. And of course, if it's making the tissue flap, that's where the air is coming in. Because the ideal place to put a patient who's having aerosol generating procedures is near that the vent where the air is leaving the space, so that it's taking any contamination with it. And then as you're doing that, be sure to check your filters. You could potentially upgrade your filter. The filters are rated by something called the MERV rating. And if your system can handle it, putting something with a MERV rating of 13 would be preferable. And then being sure that you change those filters regularly. Ensure that the staff spaces, the non-clinical spaces are clean to the extent possible. And then if you are concerned about ventilation, you can do things like, if you have windows, open the windows to increase the amount of fresh air that's coming in. You can get freestanding HEPA filter units to put, near the patient areas. And when you do that, just be sure that you don't place a person between the patient and the filter, because you don't want it drawing the aerosols across the dentist or the dental assistant or hygienist to the filter. You want to put the filter where it's going to draw it away from those people. Next. Also, if you have any break rooms or shared office space or the registration spaces where more than one person works, they need to be cleaned regularly. If anybody's, say, sharing equipment like computer equipment, that also needs to be cleaned or disinfected between different people using it. And if the space allows, for staff to be sequestered, say, people have their own office or their own little area, and it's sufficiently isolated from others, they could be in that space without masking, but otherwise everybody should have a mask or face covering on at all times. And then be sure that when you go into supply and storage areas that you're wearing clean PPE, or you're not wearing PPE, but you do have your mask on, and that you're handling things with either clean hands or clean gloves. Another thing that you can do is, if it's possible, and you have, say, a break room where you can't really properly distance to have your meals, think about alternating meal breaks to avoid team members from sharing the same space while eating and drinking. Next. And of course, all of the team members should be screened every time they come into the facility to work. And that is self-reporting of symptoms that would prevent them from presenting to work. Should be done before they arrive. So having a checklist, or some people have developed applications where they can, it's an app where you go on and you answer the questions and it tells you whether or not you can go to work. But do that before you come to work so that you can prevent a person from coming in who does have symptoms that should make them seek medical advice as to whether or not they need to quarantine. And then on-site screening for temperatures of 100 degrees or higher Fahrenheit, and checking in on those symptoms every day. And as we said, not only are we wearing masks for PPE, but we're wearing them for source control, where just in case we might be infectious, that wearing of that face mask or face covering will help prevent us from spreading our droplets and aerosols around. Next. And I just want to very briefly talk a little bit about the type of testing that's available to detect COVID-19. And there's really two primary tests that are being used. One is and the types of tests, it's what they're looking for. There may be different ways of doing these tests, but there's really two things they're looking for. They're looking for the RNA of the virus, or they're looking for the antigen, which is a part of the virus. So they're looking to see whether or not virus is circulating in the person's body fluids. So with molecular test, or the PCR, which is really the gold standard, the test that would be done on both symptomatic and asymptomatic people, requires a sample from either the back of the throat or the mouth. There's an oral swab that can be done. It's processed by a laboratory. It requires, certain certifications. It's a high complexity laboratory analysis, so it's not something that can be done in the office. It should not be used to determine if an infection has resolved, because once a person has COVID-19, the RNA of the virus could be detected for weeks or months after the person's no longer infected. It's just because some particles of the virus or the RNA may remain. So really, you don't use that test to clear a person to come back from work. There's another process for that, and it has to do with timing of the symptoms and how long it's been since they tested positive. And there's a whole protocol for that. The antigen test just detects the antigen from present circulating virus, and it can be done with either blood or saliva. It's a rapid point of care test, which means that the test can be done and read at the same site. It may require, depending on, it does require something called a CLIA certificate of waiver. So, these tests are not to be done unless a person has the proper certification for doing that. And the possibility of false positive tests does exist with antigen. It does not exist with a PCR. PCR is, since it's looking for the RNA, if it's not there, it's not going to find it and it's not going to report it. But the antigen test isn't quite as sensitive, and it can pick up. It might not recognize that the antigen is from the SARS coronavirus. It's not as reliable as it is for PCR, and it's cleared by the FDA for use with symptomatic patients. Next. So I want to talk about PPE because that's really been a big change for all of us, is the way we manage our PPE, and we're relying on it a lot more than we ever, well, we always relied on it, but maybe we're relying on it a lot more than we previously realized that we did. This is just an infographic from the CDC showing that when you're treating patients, it's preferred that you wear a face shield or goggles and a respirator, clean non-sterile gloves, and an isolation gown. But an acceptable alternative would be all of that same PPE, but a face mask, or a surgical face mask, a medical mask, instead of a respirator. Next. So this is kind of breaking down the CDC interim guidance for dentistry during COVID-19, and that's for procedures likely to generate splashes, gloves, eye protection gown, and a surgical mask. For aerosol generating procedures, glove, eye protection gown, and an N95 or higher level respirator. And the same would go for patients with suspected or confirmed COVID-19, although if you're doing aerosol generating procedures on those patients, again, you might need to refer them to a facility that has an airborne isolation room. Next. One of the things you want to be sure people are doing is using PPE properly. And as I mentioned, and as Kathy mentioned, there's been some changes during COVID-19 to the recommendations, both for the type of PPE that we use, but also the order and manner in which we put it on and take it off. This URL that's listed here and that's just popped up in your chat will take you to these infographics, which might be a nice tool to use to help train the rest of the office in the recommended donning and doffing, or putting on and taking off of PPE. Next. So now what's recommended is that before you enter the patient room or approach the patient, the treatment chair, that you first perform hand hygiene, that you put on a clean gown or protective covering that covers all of your personal clothing and skin that could have contact with the patient body fluids. If they become soiled during the procedure, they should be changed. Put on a surgical mask or respirator next, and be sure to put it on correctly. I'll talk a little bit about the use of the respirator, since that's a new bit of PPE for us, and what a seal check is. Next. And then next you would put on your eye protection, which would not be personal eyeglasses or contact lenses. Obviously you would be wearing a face shield or goggles with side shields, something like that provides full eye protection. And then finally, put on your clean, non-sterile gloves. And then you enter the patient room. So that's really different, because we used to go in, greet the patient, talk to them for a while, and then put on our mask and our eye protection, wash our hands and put on our gloves. So now we're going in there already protected. And of course, that's because of COVID-19 potentially being airborne. Next. And then at the end of the procedure, after you've dismissed the patient, you would remove your gloves and then remove your gown or protective clothing, and be careful in the way that you remove it. Untie it at the neck and the waist, and then pull it off inside out. Same thing with gloves. When you're removing the gloves, you should grasp the cuff of one glove and pull it off inside out, and then you can use your finger to pull off the other glove by sliding the finger between the glove and your wrist and pulling it off inside out. You don't want to touch the outside of the gloves. And same thing with the disposable gowns, pull it off inside out so you're not touching the outside of it. You're only touching the inside that's been against your clothing. And then now is when you would exit the patient room or care area and perform hand hygiene. And you may have to make some modifications to this based on your own facility and the way that you do things. For instance, maybe you don't have a sink outside of the treatment room. Well, then of course you'd wash your hands before you exit the room. Next. You would also then remove your eye protection by grabbing the straps and pulling it upwards and away from your head, and clean and disinfect it if it's reusable, or discard it if it's disposable. And this is where the last thing you would do is remove your mask or respirator and then perform hand hygiene. Next. I put this slide in here because we do get a lot of questions, it seems, about surgical masks. There's been, a lot of discussion about these different levels of surgical masks. And surgical masks are evaluated based on several different characteristics. How well do they filter bacteria? Well, level 1 is greater than 95%, and 2 and 3 are greater than 98. Not a huge difference there. I mean, that's the same. N95 respirators have a 95% filtration rate, but they also have a better seal. That's why they're a better respiratory protection. It's not because they filter more, it's because they seal better and don't allow things to escape in or out around the sides. And then they look at even smaller particles, these submicron particles. Again, same filtration efficacy for level 2 and 3, and level 1 slightly lower. The main difference in level 1, level 2, and level 3 masks are their resistance to penetration of synthetic blood, which is basically their fluid resistance. And so really any one of these 3 levels is appropriate for use in a dental setting as part of your PPE. It's just that if you're doing aerosol generating procedures that are generating a lot of fluids, you might need to change your mask more often if you're using a level 1. Next. I'm going to talk a little bit about respirators in the context of your PPE. We have to remember that there are a number of government agencies that may address the issue of respirators. There's certainly NIOSH, which approves approves respirators, tests them. The FDA approves respirators that are for medical use. The CDC makes guidelines related to respirators as they fit into our PPE. But OSHA actually regulates the use of respirators in workplaces. And some of the regulations include things such as employers have to institute engineering and work practice controls before they resort to PPE as a measure to protect workers. That if you're going to use respirators, there must be a written respiratory protection program and an administrator assigned to administer that program. And before an employee can use a respirator, they need to have a medical examination, which is basically a questionnaire, by a qualified health provider, and then receive fit testing and training, including training on COVID-19. And OSHA's modified some of these requirements, and you should really look at both the federal OSHA website, but if you're in a state, with a state OSHA program, you need to be checking their website too, because they may have additional requirements related to this. Most of them are not requiring the annual fit testing anymore temporarily, but they still do require the initial fit test for respirators. So I thought I'd talk about this respiratory protection program administrator role just a little bit, because I think that this is something that the dental assistant, as the infection control coordinator or sort of the infection control lead in the office, could potentially fill this role. They monitor and conduct an exposure assessment. They maintain records. They develop those specific programs that are geared towards your work site, and then they conduct program evaluations. Next. And then respirator fit testing can be done by an employer or by an outside party, either one. It needs to be done initially and annually, although as I mentioned, annual fit test is temporarily not required. You do need to do another fit test though if you change brands of respirators, because they're all going to fit differently. This fit test uses an agent such as something that's bitter or sweet to check whether there's leakage around the respirator. And you see a fit test kit looks something like this. You put that yellow hood, the person puts on the respirator, they put the yellow hood over, and then they have these little blue things, they're called nebulizers, that put a little bit of spray that either tastes better or tastes sweet underneath. And if you can't detect it, that means that the respirator fits right. But there are instructions for that too. So if you're going to do your own fit testing, be sure to get all the training materials from the company that you buy your fit test kit from. Next. This is just an infographic. I'm not going to read it in detail, but in the first picture, it shows that you hold your respirator in the palm of your hand, put it against your face, and this is a clean respirator, so they're doing it with no gloves on. You bring the strap over your head and to the nape of your neck, and then you take the top strap and you bring it up and over to the crown of your head. Using two hands, you press on the metal bar. Don't pinch it with two fingers from one hand. Rather, press it so that you're forming it along the bridge of your nose and to the sides of your nose. Put both hands over the respirator and take a quick breath in and then breathe out. If you feel any leakage, or like if you're wearing glasses and they fog up, you need to adjust the respirator, because if air is escaping, the respirator isn't fitting correctly. So once you've got it all fitted and it's not leaking, then just take your other PPE and put that on. But be aware that other PPE potentially could interfere with the fit or performance of your respirator. So you want to be careful about anything that comes into contact with it, including, putting other masks over it, or, that could interrupt the seal, or if you have clothing or glasses or anything like that that's coming into contact with the respirator, make sure that it's not interfering with the seal. Next. And of course, don't use respirators that are damaged or deformed. We really should not be reusing respirators at all unless there's a significant shortage, and only then, by following certain protocols. We did a webinar on optimization of PPE that you could get from the same, from OSAP, that you could watch if you didn't see it. You can't have facial hair that comes into contact with the respirator. It needs to be shaved. And don't crisscross the straps in the back. And if it doesn't have a proper seal, it's not working, try to get help from somebody to get it to fit properly. And if it's been fit tested and it worked, you should be able to adjust it to the point where you do get a good seal. And then when you're taking it off, what you do is you pull the neck strap out and up over your head first, and then you grab it by the strap that's over the crown of your head and pull it off away from your face so that it's just dangling by the strap, and then you discard it. Next. With the N95 shortage, I know that a lot of us have had to use respirators, and it's been authorized for us to use respirators that are approved for other uses, but a surgical respirator would look like this one on the left, and it provides both source control and PPE, so it protects you and it protects your patients. But when you have respirators such as the one on the right with an exhalation valve, that does not provide source control. It has a valve that doesn't allow you to breathe anything in through the valve, but you can breathe out through the valve. So it's not source control and should not be used. Next, unless you can cover it. Sometimes you can cover up that valve. Next. I won't go into great detail on this, but the NIOSH guidelines for extended use and limited reuse of respirators in healthcare settings go into some more detail. And that is that if you're using a respirator following an aerosol generating procedure, it should be discarded. It also needs to be discarded if it's contaminated with blood or other secretions or body fluids. And then also really think about using a cleanable face shield over the N95. I'll talk in a second about how much it does reduce surface contamination. And then if you have to reuse respirators, hang them in a designated storage area or keep them in a clean, breathable container, and make sure that you understand which person that respirator belongs to so that you're not sharing it with another person. Next. Oops. Wasn't there one before that? Yeah, so if you're going to reuse respirators, make sure you clean your hands with soap and water or an alcohol-based hand rub before and after touching or adjusting it. It really shouldn't be touched or adjusted while you're treating the patient. And don't touch the inside of it, because that will contaminate it and you don't want to put that on your face. and use a pair of clean gloves when you're putting on a used N95, because remember, it's considered a contaminated item, and also wear gloves when doing your seal check, and then discard the gloves, and you're going to have to do hand hygiene and get clean gloves for the next patient. Next. I wanted to share these toolkits because I think they're very useful. OSHA has a sample written respiratory protection program, and so you can use that to develop your own written program if you don't have one. NIOSH has a great variety of information on the use of respirators, along with some training videos on how to don and doff PE and other things too. So there's really a lot of resources out there for you. You just have to spend some time looking at them. And I wanted to share the AAOHN, that's the American Association of Occupational Health Nurses, because they have a lot of training videos on their website. These are free. They were developed through funding from NIOSH. And there's two separate training videos on their website. One is for the Respiratory Protection Program Administrator. So there you go. If you're going to be that person in the office, you can take that training, you get a certificate, and you know that really shows that you're qualified to do that. And the other one is just the general respirator training that everybody who's taking a respirator could take to meet the requirement by OSHA to have training. Next. Face shields do provide good protection. There are some studies that have been done that showed that, at least with influenza, that you could reduce the inhalation exposure of the person wearing it by 96% in the period immediately after a cough, and that it reduced the surface contamination of the person's respirator by 97%. Next. So some of the other things that are really important to do are to think about what you need to do in terms of your policies and protocols, because you do need to modify your existing policies and protocols to address the current pandemic, and because things are different, and that should be in writing. Develop, if you haven't already done so, you can help by developing the written respiratory protection and policy, and then develop an exposure management plan. Look to the public health department for help on this, because a lot of them have a requirement for you to develop a health and safety plan anyway, and what you need to include in that. But certainly you want to know, what is the definition of a COVID-19 exposure, and what do you do if that happens in your practice? What is the reporting process if somebody does either test positive or have an exposure, say outside of the workplace, and it's an employee or a patient, and they want to know, what am I supposed to do? What is the role of your local public health department for contact tracing? From my experience, our campuses in my university are in 3 different counties in California. So 3 different cities, 3 different counties, very, very different resources from their public health departments. And so some public health departments can't help you much with contact tracing at all. They don't have the resources, and others have tons of guidance. They'll help you, they'll actually do it. So you need to find out, what can you expect in terms of assistance from your local public health department if you do have a case of COVID-19 on your campus, or excuse me, in your clinic, and that you feel that people have been exposed in the workplace. Also look to local, address your quarantine and self-isolation needs in your exposure management plan, and always review your local public health directives so that you're checking for updates on a regular basis. They might have, I've seen counties and states that have directives specifically for dentistry. And you can look in there and see if there's any restrictions on what you should be doing. Next. We've just listed a few additional resources here for you, and you can check these out at your leisure. Next. One of the resources that OSAP can help you with is this joint project between OSAP and the DentaQuest partnership, and it's the best practices for infection control in dental clinics during the COVID-19 pandemic. One of the nice things about this particular document is that if things change, this will get updated. And it has sort of a checklist layout. So it kind of walks you through all the things that should be done. And it's really based on the evidence-based guidances such as those from the CDC. Next. There's also another resource that's been developed between OSAP and INQUIST partnership, and that is this dental patient care in the era of COVID-19. So this is information that can be provided to patients so that they understand better what kind of safety precautions are being done to make it safe for them to continue to receive dental care. Next. I just want to remind you that there will be a dental infection control boot camp from OSAP, January 25th through 28th. It'll be a virtual conference. Next. And at this point, I know that we're running low on time, but we do have a few minutes. I see that there's some questions in the Q&A box, and if you want to put any other questions in there, go ahead. But Kathy and I will take a look at this. Kathy, why don't you start?
Let me open it. What about using an ultrasonic cleaner in the sterilization room? Will that create an aerosol generating procedure? Not if you keep the lid on and keep it on the entire time that it's running. I think that would be safe enough to do. Eve, would you have anything to add to that?
No, I agree with that. I have one here. Should a respirator be removed after each patient? And the answer to that is yes, but if we are in a situation, you really should go online to the CDC and look at their, it's called the guidance for optimization of PPE. So if you just do that as a search, you'll come across it. We also, as I said before, we did a webinar on it with some more details that you can get from OSAP. A respirator is considered single use, just like a mask would be. However, if there's a shortage of respirators, you could extend the use of them, which means that you leave it on for multiple patients and you just don't, you don't touch it or anything like that. You just leave it on. And then if there's a critical shortage where you really can't get any more respirators, or you have such a small supply that you're about to run out and you're not getting any, there's none available, you could potentially reuse the respirator. Again, if you remember, we just talked about the NIOSH guidelines, and they did say that they do not recommend that you would reuse a respirator that had been worn during an aerosol generating procedure. But there are some strategies, whether it's hanging it up or putting it in a container, for 48 hours, and then you can wear it again, but you would have to still consider that contaminated, and you want to avoid putting something that's potentially contaminated on your face and handling it with your gloved hands and everything. Would you add anything to that, Kathy?
No, I think that's, you addressed it quite well. There's another question here. It says, do we need to be refit tested if we change from a 3M 8210 to the 3M 8210 plus? Because I don't know what those exactly look like. I think it would be important to know if it's a different respirator, not in the same category as the one that you're wearing, you would need to be refit tested. There may be some information on the NIOSH website that may list some of the respirators that are considered compatible one to the other.
I'll just be different here and take the non-COVID question. Are burrs needing to be disposed of after each use, or can we still sterilize them? This is a topic that's come up a lot and at our OSAP meetings, and we've had representatives from FDA there to help address this, since they are the ones who clear products to market and the claims. And according to the FDA, there are no diamond burrs that have been approved for reprocessing, because the manufacturer would be required to submit those reprocessing instructions that have been validated and shown to be effective, and none have done so. And so the official FDA word on that is that burrs should be considered a single-use item. Anything to add to that, Kathy?
Only that the important thing is, if you have any questions specific to it, you should contact the manufacturer of the burr, not necessarily the sales representative, but the manufacturer directly, and ask them for their validated reprocessing instructions. If they can't provide that, and many do not have them, then they would be considered single use. I think
And you can
we're
also,
okay.
I was gonna say, you
Sorry,
can also ask the FDA. It's through their device and radiological health branch.
Yeah, I think we're at time, Eve.
Yeah.
And I'll turn it back over to Ashley, but I thank you all very much for your time and attention today. And I wish you all well and safe holidays.
Yes, thank you all.
Yes, thank you, Eve and Kathy. We always love having you as our speakers. This is just a little bit about CE. So in order to receive your CE verification letter, you'll need to complete a brief online assessment and evaluation. When the webinar ends, there will be, I believe it's a button that will pop up that can bring you directly to the online assessment. And this has also been added to the chat, the link for the assessment. So if you have any troubles, please feel free to reach out to OSAP at office@osap.org, and we can definitely help you. A recording of the webinar will be added to the OSAP website within the next hour or so, and is available to anybody. So if you know anyone who was unable to make it will be up there and available, and it will include all of the links as well that have been provided throughout the webinar. And I think with that, thank you to everyone for joining us on this Friday.